Hi, I'm Dr. Jen. I'm a board certified fertility doctor, and I'm talking today about Goldilocks IVF or just right IVF for you. So, I'm Dr. Jen. I'm a board certified fertility doctor, and I'm talking about Goldilocks IVF or just the right type of IVF for you and your body. So, this is a more personalized approach to IVF. An older way to call it would be maybe mini IVF, but that's really still a set protocol, which tends to use lower medications. And the personalized or Goldilocks approach to IVF does not limit the medications, but gives them in just right doses for you. So that's the difference between those two. But after I go through the topic, I will take questions. Again, Dr. Jen, I'm a fertility specialist, and today I want to talk about something that I'm really passionate about, which is personalized IVF, or as I like to call it, the just right amount of medication, the Goldilocks IVF, not too much medication, but also not too little, but really looking at your body and your hormones and getting the just right dosage of medication for you. So it's really tailored to factors like your age, your hormone levels, your AMH, your antral follicle count, or the follicle count on ultrasound, so the exact number of eggs you have in your ovary each month. Um, And the goal, so older IVF is really was developed where instead of growing and ovulating one egg a month, you took fertility medication so that you could grow a whole group of eggs and collect those eggs to give you a better chance of pregnancy. And that's in part why IVF works to improve fertility. But the older way to do this is to give really high dose injections. I think that's how everyone thinks of IVF, is that it requires very heavy medications and very heavy injections. That is really honestly an older way to do IVF. There are newer medications and ways to do IVF where you can really take minimal injections and you can take pills, but it's not those really high dose multiple injections a day. That really, I just want to get the word out there for everybody that really is an older way to do IVF. And the newer, more modern way is a personalized approach, which turns out that your body doesn't need all those injections and high hormones to do an IVF cycle. Usually with personalized IVF, I find that it involves one injection a day plus some pills. And the pills will increase your natural hormones and also hold the eggs so they don't ovulate too early. Usually you're on these medications for 10 to 14 days to allow a group of eggs to grow. Now, every month your body will naturally have a group of eggs that will start to grow, but naturally your body releases enough hormones for only one to ovulate. That's why natural twins are very rare. But the rest of that group of eggs does die off. But with fertility medications, you get that whole group of eggs to grow and then ideally collect a group of eggs. So, but it doesn't use up your egg supply for the future because you would lose those eggs that month anyway. But it turns out to get that group of eggs to grow, you really don't need super heavy, high dose hormone injections. So what you have to do is your body will naturally make a hormone called FSH, and that's the hormone that allows the one egg to grow and mature. So you can increase FSH to get that group of eggs to grow in two ways. You can do that through heavy injections, but that almost overdoes it. So what are those injections? They're actually FSH, that hormone. So you're just giving yourself massive doses of FSH to try to push that group of eggs to grow. But it turns out, which makes sense, that the eggs grow better when you're getting a nice medium level of FSH. You don't really have to massively overdo with so many injections to get that group of eggs to grow. Eggs grow better and mature better when they're given a Goldilocks dose, a just right dose of medications for that group of eggs to grow. And how do you do that? There's two ways to do that. One of it is a pill, that Clomid or letrozole is often used for this. What this will do is it will naturally cause your brain to increase the FSH. So you're naturally making these hormones. The older way to do IVF, the really older way to do IVF was just to completely shut down all your brain's hormones and then replace it all with massive injections of hormones. So, and it's still a really common way to do IVF, where you just give yourself massive doses of that hormone FSH. But your body makes this hormone. So with pills, you can get your body to make more of this hormone naturally. And sometimes the body won't, you'll need a little bit more. So oftentimes with this Goldilocks approach to IVF, or the just right approach, you will still take one lower dose injection a day of the FSH medication called Gonal-F or Follistim, but it's usually lower, and that's usually the only injection you're taking the whole way through the IVF cycle, because your body will naturally make a lot of FSH. If you don't shut your body down, your body will sort of contribute to getting those eggs to grow and make FSH on its own as well. So with this approach to IVF, it's important to check FSH levels all through the cycle, because you always want to be adjusting for that just right Goldilocks dose of medications to get your eggs to grow that cycle. The really nice thing about this type of IVF is it uses way less injections than traditional IVF. So I usually see my patients are on maybe a quarter of the doses of hormones and injections than the older, more conventional traditional IVF when we're using this personalized IVF approach. So I really, and really it will get that whole group of eggs to grow really nicely. We are focusing on the quality of eggs. But I've had many patients who have come to me over the years who have done conventional IVF and that didn't work for them. And they're coming to see me for a more personalized approach to IVF. And I would say we get very similar egg numbers to those massive doses of hormones that are used in conventional IVF. But the eggs, we're focusing on those quality eggs. And honestly, the eggs can get overwhelmed by those massive doses of hormones and not always work as well. So the eggs respond better to that nice Goldilocks level of FSH and medications. So it doesn't mean you're going to get a lot fewer eggs, but we are concentrating on the quality eggs and the quality eggs to go on and make quality embryos as well. So I'm Dr. Jen. I'm a board-certified fertility doctor, and I'm talking about personalized IVF protocols, which tend to be much lower injection. So the other thing to know about personalized IVF is because you're using up so many fewer injections, the side effects tend to be less. So when a group of eggs grow, your ovaries will be tender because they're used to growing and ovulating only one egg a month. And when a whole group of eggs grows, it does tend to cause the ovaries to be more tender. So you will get some of that tenderness, but I find without the massive hormone doses, there tends to be less tenderness and less bloating. And honestly, just fewer side effects overall, which makes sense because your body's contributing a lot of the natural hormones. You don't have to take so many multiple injections a day. Conventional IVF is usually most commonly 3 injections a day. It's a lot. And again, this personalized Goldilocks IVF is usually just 1 small injection a day. So you get a lot fewer side effects. And honestly, I think the eggs grow really well, a lot better. So who is this type of IVF for? Honestly, everybody, in my opinion and in my experience, and I have done at this point probably thousands of IVF cycles. I don't see that anyone needs super high hormones to do IVF. Again, it's a bit of an older way to do it. And, there's newer ways to do IVF. You don't need to take massive doses of hormones. Anybody who is doing IVF could and should do this personalized approach to IVF. Why not take fewer injections and take less medications and have the eggs grow as well, or in my opinion, better? So I think the personalized Goldilocks type of IVF could be or is good for anyone doing IVF. But in particular, I have seen women with low egg reserve, low AMH, or women over the age of 40 doing IVF, that often those women may respond very badly to the massive high-dose conventional IVF. So I have had patients come to me who have done and failed at conventional IVF, who we can get eggs to grow and collect mature eggs using this more personalized approach to IVF. But again, anybody is a candidate for this type of IVF because it's a much nicer type with many fewer injections. But in particular, I have seen that women, again, with low egg reserve or over age 40, really almost need this type of IVF. That traditional high dose injection or high dose hormone just doesn't not work well. And why is that? Because what we're doing with IVF is we're increasing that FSH hormone to the just right level to get the eggs to grow. But when women have low AMH, or low egg reserve, their baseline levels of FSH tend to be really high. That's why you probably hear of, oh, my FSH is high. When women are going into menopause, we screen that through really high FSH levels. So if you have low egg reserve and your FSH is already starting to become high, and then you give yourself massive injections and doses of FSH, you can see why that would make sense. That doesn't make the eggs grow better. There already is a really high amounts of FSH in your body. So injecting massive amounts more of FSH just doesn't work. So that's why for women with over age 40 or low AMH really need this type of IVF. But again, this IVF works well for anybody because it's fewer injections, fewer side effects, and more personalized. And so how does this actually, how does it work? Basically, a brief overview is that sometimes you'll do priming before your menstrual cycle. So sometimes I would say the IVF cycle even starts before your menstrual cycle. So you would do priming with estrogen or birth control before your menstrual cycle to keep your hormones balanced. When you get your period, then you'll start on these medications to grow the group of eggs. So usually with personalized IVF, that means 1 or 2 pills and 1 injection a day. And you're on these medications for, on average, 10 to 12 days. That's how long it takes for that group of eggs to grow. And while you're on these medications, we always need to be adjusting the doses of medications through. So you don't just take 1 dose and stay on that dose for the whole 10 or 12 days, because as eggs grow, their hormones need to change. And so you need to change the dose of the medication as you're going through those 10 or 12 days. So how do we know how to change the dose of medication? During those 12 days, you're going to come in for what's called monitoring, where you get an ultrasound and blood work. And part of what I'm checking is that FSH hormone. And we're adjusting the medications to what the eggs need through your IVF cycle. So you may come in a few times, maybe 3-4 times for monitoring while you're on the medications. Then when we see the whole group of eggs has grown to the right size, now sometimes they grow at different sizes, so we're always balancing the needs of the eggs growing bigger with the eggs that are smaller. But once we get the group to the ideal size for that group of eggs, what we do is we basically start the ovulation process. So you'll take what's called the trigger injection that starts the egg to grow and mature and begin to ovulate. And then the egg retrieval is about 36 hours later. So we collect the eggs basically as they're starting to naturally ovulate, but before they release. So it's a very precisely timed procedure. You can't, I've had patients where maybe they got stuck and couldn't get there for a few hours later. Usually the eggs are gone at that point. They've ovulated. So it is a very precisely timed procedure so that we can collect the eggs just as they're naturally ovulating. And we'll collect the whole group of eggs. Sometimes not every follicle will have an egg. Sometimes as we're going in to suction out the eggs, not every single follicle that was part of the group will have an egg that we can suction out. So that's something to keep in mind too. But that's how it works. And then from there, the eggs are then fertilized for IVF. Sometimes they can be frozen for egg freezing, but that's about the 2-week process. Now, after the eggs are collected, that's sort of like your natural ovulation day. It would be your natural ovulation day in your cycle. So then you would expect a normal menstrual period about 2 weeks later. So I'm Dr. Jen. I'm a board-certified fertility doctor for those just joining, and I'm talking about personalized approaches to IVF and why they're better than the older high-dose hormone methods of doing IVF. please subscribe if you want more content like this. This is my specialty, is personalized IVF. I've helped thousands of women with personalized IVF, and it's really a much nicer type of IVF. So I will start to take questions specifically about IVF tonight. So I'm Dr. Jen. I'm a board certified fertility doctor talking today about personalized IVF, which tends to be a lower dose hormones and fewer side effects and focused on good quality eggs. So let me know if you have any questions about IVF medications, and stimulation protocol types. So I will take some questions and answers about IVF. Let's see here. Okay, so thanks you everyone for joining. Um, let's see. Poppy says, wife's 29 years old, diagnosed with DOR or decreased ovarian reserve, and the fertility clinic said IVF would be an uphill battle. So it's I don't know if I would call it an uphill battle, but it can take more work, IVF, if you have low egg reserve. And what I mean by that is that sometimes, without knowing her AMH, it's hard for me to say for sure, but sometimes it can take more than one egg retrieval to get a viable egg or embryo. So it can take more work. That's what I tell my patients who have very low egg reserve or AMH, that you can get pregnant, depending on your situation, but it can take more work because you have that low egg reserve. And what that means is in that group of eggs, not as many will grow in response to the medication. So you won't be able to collect as many in one cycle. But if you collect over a few cycles, then you'll get that number that you need, especially at age 29. But the other thing to keep in mind is what I'm talking about tonight is this type of personalized IVF, which is important for women with low egg reserve, because if they give massive doses of medication in the IVF protocol, you may see eggs not grow. And what happens, again, when you have low egg reserve, your FSH is naturally high. And if you take massive doses of FSH injections, it overwhelms the eggs and they just freeze and don't grow. So I have seen many patients who have come to me saying they had low egg reserve, they did conventional IVF, and the IVF was canceled because the eggs didn't grow. So I know right away, okay, that was just, they were taking way too high doses of FSH for their eggs and what their body needed. So make sure you ask about protocols for DOR. And if they have different protocols for DOR than their standard protocol, that's a question I would ask your fertility clinic. Okay. Let's see. So would I recommend to remove a uterine polyp before transfer? In general, yes. A polyp is an overgrowth of the uterine lining that can cause inflammation and will decrease the chances of the transfer working. So in general, you want to remove through a hysteroscopy a uterine polyp before doing an embryo transfer. Tina says, I'm going to have my first egg retrieval the week I turn 39. Am I too old? So 39 years old is not too old for an egg retrieval. I've had hundreds of patients at age 39 get pregnant doing IVF at age 39. So you're definitely not too old for an egg retrieval. The thing to keep in mind is some women at age 39 will show signs of decreased ovarian reserve. So if that's the case for you, sometimes at age 39, you do one egg retrieval and you don't get the viable egg that's going to grow into a pregnancy, and you need to do a second egg retrieval. That can sometimes happen, not always at age 39, but sometimes that happens at age 39, where you're in that group where it can take a little bit more work for IVF to work. But fingers crossed, and best wishes for your first egg retrieval. Okay. So let's see. So someone's asking about adenomyosis and 3 months of downregulation. So what that can be is taking Lupron to basically try to shrink the adenomyosis before doing, I'm assuming, an embryo transfer. So adenomyosis is, simply put, when endometriosis grows into the muscle of the uterus. This decreases your fertility because, in part, it will decrease the ability of the embryo to implant. So Lupron tries to shrink that endometriosis, basically that's been growing into the uterine muscle and infiltrating the muscle. And it has been shown to help with embryo implantation, uterine receptivity, if it's treated before the embryo transfer. So whether you should do it would depend, I would say, on your embryos, if you've tried embryo transfers that haven't worked in the past, but is something that can be considered for women with adenomyosis prior to an embryo transfer. Mike says, is there anything guys should be doing to improve our fertility health? I'm very glad to have a guy on here asking about men's fertility. So yes, so men are very different. So I've been talking about women and how they have a group of eggs that grows and then dies each month. They're born with all their eggs and they just decrease over time. Now, men make millions of sperm every day. So what that translates into is that lifestyle changes can have a really big impact on sperm and men's fertility. So what I'm talking about is leading a healthy lifestyle, like getting exercise daily, getting 8 hours of sleep a night, focusing on a Mediterranean type diet with low red meat and lots of fruits and vegetables. Also, walnuts are supposed to be good for sperm. And also supplements have been shown to improve sperm parameters if they are low. So like a men's multivitamin, CoQ10 is a supplement that can help when there's problems seen on a semen analysis. But the bottom line to remember is that men are making millions of sperm every day. So honestly, what I've seen as a fertility doctor is that lifestyle changes have a bigger, more immediate impact on sperm and sperm fertility than even on egg health because of that huge difference of men making millions of sperm every day. Okay, let's see. How can a woman enhance her egg quality? So we're just talking about sperm quality, which is a little bit of an easier fix just because of the physiology behind it. But egg quality can also maybe improved by supplements, CoQ10 being the main supplement that has been shown to improve egg quality or possibly improve egg quality if you take that prior to doing an IVF cycle. The other thing that shows promise that I've used on a lot of my patients is ovarian PRP, which is a procedure where PRP is put into the ovary before IVF. PRP has growth factors and hormones, and that can help the eggs work better. And the effects of that will last for a few months. So that's like a boost for egg quality that can last then for a few months. Can you comment on Omni for egg quality? So I believe you're talking about Omnitrope, which is growth hormone. So that's something that has become more common is to take an injection. So this is an injection of hormone. So I am not as big a fan of taking lots of injections, but there is some evidence that taking a low dose human growth hormone during your IVF cycle can improve outcomes. It's not the strongest evidence, but there is some evidence for that. Let's see. So I'm Dr. Jen, and I'm taking questions about IVF. Okay, what's the optimal FSH and AMH for age 40? So those are hormones. FSH and AMH are hormones that look at egg reserve. So FSH will change all the time because every month you'll have a different FSH level on day 3. It's usually checked on day 3 because that's when your estrogen's low in the cycle. So you'll get what we consider a true reading of the FSH. Sometimes, and you want to always check both together, estrogen and FSH. As your estrogen increases as your eggs are growing, your FSH will naturally go low. So FSH is best checked at the beginning of your cycle, along with your estrogen, to make sure you're getting an accurate reading on the FSH. And And generally, less than 15 or 12 is considered good for that cycle, as long as your estrogen's reading low. AMH at age 40, so AMH is also a blood test. You can check it throughout your cycle. And so that's nice. It doesn't have to be on a certain cycle day. And off the top of my head, at age 40, I would say around a 1 for your AMH. If you have a lower AMH, it doesn't mean that you can't get pregnant or you can't do IVF, but that would put more urgency into the situation. Honestly, at age 40, that's sort of like a big cutoff where we say, really, if you want to be having a family, you want to be getting pregnant, now is the time, because as you wait longer past the age of 40, all these parameters dramatically change, including your FSH, your AMH, your egg reserve. It's really very dramatic after age 40. So now you have this window where you can still harness your fertility. So thank you for your question. Let's see. So I'm talking about IVF, especially personalized IVF. IVF Warrior says, what if you are like 40 minutes late for your egg retrieval? Does that affect anything? So I was talking about the timing for the egg retrieval because the last medication you take, or one of the last medications you take, is an injection called a trigger shot, which could be a medication called Avidril or Lupron. That's generally taken about 36 hours before your egg retrieval, because shortly after that, the eggs will start to naturally ovulate. And I have seen patients where when the egg retrieval was done late, they have ovulated some of the eggs that grew during the cycle, which is always so hard. But in general, in my experience, 40 minutes, if I'm going in and doing an egg retrieval and it's 40 minutes after it was scheduled, I'm not too worried about ovulation. We do have a little bit of a buffer for 30 minutes to an hour before I'm really starting to worry that the eggs are going to be ovulating on their own. But it's not ideal always. But, it depends. The trigger, that is something that's personalized too. I didn't mention that earlier, but that's something I really personalize too, because there's some women that do better when their eggs are collected at 35 hours after a trigger, some at 36. And I've had some patients that do better at 37 hours after a trigger for their egg retrieval. So that's something that's really nice to personalize as well when we're talking about personalized IVF. Let's see. So we're talking about IVF and IVF stimulation protocol. So thank you for all your questions. So let me know if you have any questions about IVF and IVF medications and protocols. Let's see. I'm trying just to look through and make sure I don't miss it, so I'm sorry about that. Eli says, my AMH is 0.25. Will IUI work? What are the real chances? And I'm 30 years old. So an AMH of 0.25 is low for your age at age 30. So I would be concerned as a fertility doctor. I would want to double check that. Also check other things such as your egg count on ultrasound to make sure that's accurate, because that seems very low for age 30. And if that's confirmed to be 0.25, IUI, in my experience, has a lower chance of working, and it may not be my first choice for you. I may consider a fertility treatment with higher success rates, like IVF. Let's see. So, when does someone need IVF? When they have endometriosis. So endometriosis is tissue that's growing inside your pelvis, sometimes on your ovaries, and that can cause infertility by causing inflammation. So I would say it's not by itself an indication for IVF. But so I have had patients with endometriosis who are having trouble getting pregnant, be able to get pregnant through IUI. But if IUI doesn't work, then that would be an indication for IVF. or if the endometriosis is growing on your ovary, like an endometrioma, and causing you to have low AMH, that can be another reason to jump to IVF. A third reason could be if endometriosis is blocking your tubes. So sometimes endometriosis can cause enough inflammation in the pelvis to block your fallopian tubes. And if you have blocked fallopian tubes, that could be a reason to move to IVF with endometriosis. Let's see. So I'm Dr. Jen, and I'm talking about personalized IVF protocols. Let's see. Shanaira says, 27, I found out I have adenomyosis, one blocked tube, and was told I needed to do IVF, but pricing makes it hard. Yes, so IVF self-pay, if you don't have insurance coverage, is expensive. There are a few things I can think of. Just look into if you have insurance options through work or your partner's work, your husband's work, you can look at those and just see if there's any fertility coverage options there. There are financing options for fertility treatment. Another thing to consider is these more personalized type protocols, because they're lower medications. These fertility medications, injection medications especially, are very expensive. So if you do a personalized approach to IVF and you're using less injections, that can make it less expensive as well. And sometimes you don't need to do the type of IVF. You do what's done with the eggs afterwards. For example, ICSI can add on to the expense, or PGT testing of the embryos can add on to the expense. So sometimes you can avoid those pieces, especially at age 27, and that can lower the cost of the IVF. And says, hi, I'm 39, 3 failed IVFs with abnormal embryos, and I have a retrieval tomorrow. What are my chances? So because you've had some failed IVFs in the past, that can mean your chances would be lower, but every egg retrieval is a fresh chance. It's a new set of eggs. It's really hard as fertility doctors to know when the egg that has viability and has a chance to grow into a pregnancy, when we'll find that egg. So if you're getting eggs and creating embryos and they're growing into embryos and you're at age 39, I really still think you have a chance, even with failed IVFs in the past. IVF Warrior said the doctor had lied because he said you were 40 minutes late for the egg retrieval and the egg ovulated. Well, I have seen that happen. It's not the most common thing, but at any point, even if you're perfectly on time for your egg retrieval, honestly, I have seen eggs ovulate at that time. Because when you think about it, we're timing that we need the ovulation process to basically start, and then we need to basically suction or grab the egg just before it ovulates. So it's a very precise timing. And sometimes even the egg retrieval is perfectly on time or just a little bit delayed. Still, sometimes I've seen eggs ovulate because we're trying to time it so precisely. Basically, the egg has to naturally start to ovulate and come off the wall of the follicle so that we can collect it. So we have this very tiny window. So even when it's timed perfectly, then I have seen eggs already be ovulated at egg retrieval, which is so hard when that happens. But something you can consider is adjusting the time of that trigger. If you now know that your eggs tend to ovulate a little bit earlier, then that's that personalized approach for next time, where you can adjust the timing of the egg retrieval without information to optimize your chances of getting eggs if you need to do another egg retrieval. Let's see. Okay, Sony says, can you talk about why starting stims at luteal phase? Okay, yeah, so this is something that I've done a lot of as well. So I can talk about luteal phase stimulation for IVF. So what that means is that usually when you're doing IVF, you're growing that group of eggs and collecting them, and then 2 weeks later you get a period. With luteal phase stimulation, sometimes it's called duostim as well. You're collecting one group of eggs, and there's another group that sort of didn't grow along with that first group that's still sitting there, but they're smaller eggs. They're usually under 10 millimeters. And basically you continue taking fertility medications and do a second egg retrieval within the same menstrual cycle. So it's a luteal phase stimulation or collection of eggs. So it can be a nice option to have. I've had some patients, especially with lower egg reserve, where that initial growth of the egg really only yielded one or two, and we see a really larger group of small eggs still sitting there that just does not respond very well to that initial stimulation. And if you continue on fertility medications, you'll get a very nice group of eggs growing up, more eggs than came out during that first follicular phase stimulation. So it's called the duostim or luteal phase stimulation. It can work well for women with low egg reserve, especially when they have follicular asynchrony, where some eggs grow ahead and you still have a small group of eggs sitting there the day of the egg retrieval. So let me know if you have any other questions about that. Isis says, 40 years old, AMH 0.48, endometriosis and adenomyosis. Do I have a pregnancy chance with IVF? So yes, in my opinion, you do have a pregnancy chance with IVF. It may not be easy, meaning endometriosis can decrease the quality of the eggs. So sometimes what I've seen in cases like yours is that where we do an egg retrieval, sometimes we can get a good quality egg the first time, but sometimes not, and sometimes can take more than one egg retrieval. And then before you do your embryo transfer, you would want to look more closely at the adenomyosis, which again is endometriosis that grows into the muscle of the uterus, to see if that needs to be treated to optimize the uterine environment for the embryo before an embryo transfer. Let's see. So 4 embryo transfers and 1 miscarriage. I'm sorry about that. And doctor said just to do another embryo transfer without changes. I would say if you've done 4 transfers, I'd want to know if your embryos were tested with the PGTA to see about their chromosome makeup, to know if that's a reason you're not getting pregnant. But I would also look more into things. At this point, I would look more into your uterus, do more checks on your uterus just to make sure you're not missing anything that's preventing the embryos from implanting. Let's see. I just missed someone's question. Okay, so how many cycles do I think a 39-year-old should have? So it would really depend on your egg reserve, but without knowing that, 39 years old, I'm going to say 1 cycle in my experience is usually enough, but not always. Sometimes you need 2 or even 3, but most commonly 1, I would say, in my experience, as long as your egg reserve is normal for your age. Let's see. I am 38 with low egg reserve and low AMH. Now going Gonal-F, will it help? Letrozole only helped a bit. So it depends if you're doing IVF. Gonal-F can help, but in my opinion, you need to be very careful with the Gonal-F because it's easy to overdo it when you have low egg reserve. So you want to make sure you're getting that just right dose, that you're checking your FSH levels through the cycle. So yes, I do use Gonal-F in my patients, but I don't use very high doses. I use it very precisely. Okay. Sarah, I have an AMH of 16 and I don't respond to letrozole or Clomid. Do I have to do IVF? Not necessarily. That's a high AMH. You may need different doses or combinations of those medications. So not necessarily, but sometimes if you're just getting no response at all with those pills, I have had patients do IVF and have really good success with IVF. So thank you for all your questions. Hi, Dr. Jen. She's my doctor. She's the best. Thank you. Okay, so thank you all for all your questions. So today I talked about personalized IVF and taking just the right dose of medication, no more of those high, heavy, multiple injections a day types of IVF. It's really not needed for anyone. Personal IVF works much better, fewer side effects, fewer injections, and it works better for your eggs. So please follow along and subscribe to my channel. There's a link in the bio if you'd like to book a consult to get more personalized advice that I'm able to give on these lives. I would love to review your history with you and give you personalized advice. I am specialized in low egg reserve, very difficult IVF cases. I've had a ton of experience, and I do see patients from all over. So check it out, subscribe, and check out the link in the bio if you want more personalized IVF advice that I'm able to give on these lives. So thanks for joining.